Well, thank you. All right. Good morning, everybody. So let's go ahead and get started, okay? How are things going? How are the studies? Hopefully it's making more sense as you read more of the content, I hope. But as always, remember you can always reach out if you have any questions or if you like to discuss any of the topics further. So today we'll be talking about calcium, vitamin D, and parathyroid hormone. All right. So these are our learning objectives, which is in your syllabus. I put this question for us to talk about. What are some of the functions of calcium in the body? What did you say? I heard bone. Okay, definitely. So bone and teeth. Okay, so the bone. Most of the calcium in the body is in the bone, and essentially the key function of calcium is for structure, maintain structure of the bone and the teeth. And often you have calcium and phosphate combining with the matrix of the bone to form the bone. And calcium phosphate complex, you had the term hydroxyapatite. That's often the complex of calcium and phosphate to form bone and teeth. Just remember that if you see, usually if there's loss of calcium from the bone, like a direct bone invasion, for example, you often will see an increase in both calcium and phosphate, okay? If there is if the bone is dumping calcium into the blood, you see both calcium and phosphate increasing because the bone is made up of calcium and phosphate. Whereas if it's a hormonal reason, like a PTH driven, you often have calcium and phosphate going in opposite directions. Muscle contraction and relaxation. So again, you guys, you've done this, right, on contractions and the role of calcium in contractions, right? If you haven't, then you will, because that's part of the physiology of muscle contraction. Other functions of calcium. Why do you get spasms when you don't have enough calcium? Nerve conduction, okay? So it's important for nerve conduction. And, inadequate calcium leads to the nerves become very unstable and you have, you get tremulous and become hyperexcitable because of the lack of calcium. What else? Anything else you can think about? Keep going. So clotting, okay? It's a key factor in the clotting cascade. Have you guys done clotting cascade? Okay, so factor 4 is calcium. So it's very important for clotting. And when you don't have enough calcium, you can have issues with clotting. Cardiac function, okay? Again, kind of in line with muscle contraction and nerve transmission. And then you also have hormonal release. We've talked about this, in different hormone, whether it's insulin, most peptide hormones that are released from secretory granules are, it's usually when you have depolarization, then you have influx of calcium, then that leads to the release of the stored hormone from the vesicles. Okay? So this is the recommended daily calcium intake. The way to remember this, everybody needs about 1,000 milligrams of calcium per day, except, when you're, around the age of 9 to 18, which is what is happening around then, puberty, okay? Or when you get older, because of the effect of, bone loss, being postmenopausal for women. And as you can see, for women, once you get to 50, 51 to 70, the recommendation goes to 1,200. So that's because of the effect of menopause. And then for men, when you get to, for everybody, when you get beyond the age of 70, then, the requirement goes up. So generally speaking, most people require about 1,000 milligrams of calcium per day. And this is looking at what happens, how is calcium regulated in the body, the balance of calcium. As this picture illustrates what happens when, like we said, we ingest about 1,000 milligrams of calcium per day, and you can see the different hormones that play a role: vitamin D, PTH, and calcitonin in the regulation of calcium to keep a balance, so that the net intake of calcium is often equal to the net output. So you can see that you take 1,000. There's some exchange between the gut and the circulation. And then there's also some exchange between the circulation and the bones, okay? But the net effect is you have a net absorption of 200 milligrams, and then that 200 milligrams is ultimately excreted in the kidneys, okay? So these different hormones work in concert with one another to make sure that this balance is maintained. As you can see, there's an exchange of about 500 milligrams between the bone and the circulation, and that is just highlighting the fact that the bone is not just a static tissue, okay? It's a living tissue. It has cells, and those cells act to move calcium in and out, to cycle calcium, and that is important for maintaining bone health. Okay, if the bone was just a solid, rigid structure, it will get weak and brittle. So you have to cycle the cells to replace, old bone and form new bone. That is why it's really important to maintain that cycling. And, for most people that don't have osteoporosis, you have a balance between the intake to the bone and release from the bone. So there's no net loss of bone. But when there is a predominant loss, more uptake from the bone, you can have gradual loss of bone density. That is when you have osteoporosis. Did you talk about osteoporosis already? Have you done musculoskeletal? Okay, so maybe you're going to do that then. But this picture illustrates what happens in bone remodeling. Okay, so during bone remodeling, like we said, bone has cells. So you have the osteoclast. So it's, line the bone and start to resorb the bone. Okay, and after resorption, osteoblast will line the resorption pit, and that leads to formation of new bone, and the cycle goes on and on and on. And if you have a balance between osteoblast and osteoclast activity, then the bone density stays stable. But if there's a predominance of osteoclast, so which is resorption, okay, compared to osteoblast, which is formation, you can have a net loss of bone, okay? So there are different things that can lead to that, different scenarios, so we're essentially talking about the risk factors for osteoporosis, okay? So those are important things to remember. So anything that shifts the balance between osteoblast and osteoclast activity in the bone will ultimately lead to either net loss or net gain of bone. Something like aging, for example, as we get older, okay, aging is one of the things that leads to a net osteoclast activity compared to osteoblast activity. And that's because as we get older, once you reach the age of 30, we have, you will have built up the most bone that you can have in your lifespan. And then from the age of 30, approximately, going older, we have a net loss of bone, okay, ultimately. Which is why, again, older people tend to be more prone to fractures. All right, we're going to do a little bit of activity, and you can use your phones and scan the code. all of the following hormone states will adversely impact bone remodeling, resulting in net bone loss, except so which one does not lead to excess loss of bone? Okay, let's see. Okay. So most of you got it correctly. And the point of this question, I put this so that we can review some of the hormones that affect the bone, okay, bone remodeling. So starting with thyroid hormone, okay, so thyroid hormone, you talked about this with Dr. Champion, it makes everything go faster. It makes things move faster. You know, metabolism is faster when you have excess thyroid hormone. And the net effect of excess thyroid function is loss of bone mineral density. As a matter of fact, patients can present with osteoporosis as the first indication of hyperthyroidism. I've had patients in the hospital that didn't know they were hyperthyroid and they had a fracture, and during their workup, you find that they were severely hyperthyroid and they've been losing weight for several months. Testosterone, one secret is the sex hormones are very important for bone. So any deficiency of the sex hormones will lead to a net bone loss. So whether it's testosterone or estrogen. So remember that. And then parathyroid hormone, we know that parathyroid, we just looked at it in the previous slide, that, it does have direct effect on the bone. When you have excess parathyroid hormone, it can lead to increased bone resorption. Now, there's a caveat to parathyroid hormone, and I would say that it's not entirely incorrect to say that excess may not necessarily cause net bone loss. And the reason for that is there is a form of, depending on how you administer parathyroid hormone. So when you give parathyroid hormone in a sustained manner, like if you have hyperparathyroidism, which we're going to talk about, hyperparathyroidism leads to bone loss because there's continuous stimulation of bone resorption. However, if you give intermittent parathyroid hormone, so if you give intermittent parathyroid hormone, you need to a net gain of bone, okay? I know it's kind of a little confusing, but that is because of the effect of parathyroid hormone. When you give it in small intermittent boluses, it leads to stimulation of a net osteoblast activity. But if you give it in a sustained, if it's received in a sustained fashion, like if you have a hyperparathyroid state, then that leads to, loss of bone. We use parathyroid hormone analogs for treating osteoporosis, as a matter of fact. There's a form of PTH injection. It's given as a daily injection, and it's effective it's an anabolic, has an anabolic effect on the bone. And then as excess estrogen, obviously, estrogen deficiency is one of the key causes of osteoporosis, which you have the term postmenopausal osteoporosis, which is a result of loss of estrogen and then the effect of that on the bone, which is why osteoporosis is more of a disease condition that you hear more about in females. It does happen in males, but it's more common in females because of the effect of the significant amount of bone that is lost around the time of menopause. And then excess cortisol, obviously, in patients with Cushing's, one of the clinical effects of excess cortisol is bone loss. So it does have a negative effect, increased osteoclast activity versus osteoblast activity. So these are the reasons for each of these, and you should at least know which hormones have effect on the bone. If not on this test, but on your board exams, you can run into this because, in the board exams, you get everything, all the hormones, all the different conditions, they can be integrated, and you might have questions like this that will test your knowledge about, what affects osteoporosis. Any questions? Okay. So distribution of calcium in the body. So total body calcium, about 99% is found in the bone and the teeth. As you can imagine, most of the calcium is in the bone and teeth, and it's calcium phosphate salts. We talked about hydroxyapatite. And then about 1% is extracellular and soft tissue, and then only about 0.1% is intracellular. But again, every fraction is really important in what they do. Serum calcium, about 40% is bound to protein, and 10% is complex, and then 50% is ionized, which is the free form of the calcium that is available for activity for all the different functions of calcium in the body. As we talked about when we're talking about hormones, binding of calcium to the protein makes it not available to the body. But when it's free and ionized, that's when it can act. It can do the different functions. And then when you're talking about protein binding, again, just like the hormones, protein binding of calcium acts as a reservoir for the calcium, so that if you have, it can serve as a pool where you can, shift calcium into the ionized form as needed. Increased serum protein, so when you have increased albumin, can result in increased total calcium. Okay, because it's bound, if there's a whole lot more binding sites, you're going to have a whole lot more calcium. Okay. However, what really matters is the free ionized calcium. So it's often important at the bottom, there's a formula that says corrected calcium. So whenever you have albumin that is not either too high or too low, you can use this formula to adjust it so that you can get the actual calcium. You're going to run into this in clinical practice all the time. You're going to have to recognize on your body exams, maybe not step 1, step 2, maybe step 2, or even in your clinical, when you start your body exam for your residency, you're going to see things like this all the time. You should recognize that if there is either a high or low calcium, you should think about what's the albumin to make sure that calcium is actually truly what it is, because albumin, changes in albumin or protein binding can affect the ultimate level of the calcium. Ionized calcium can be affected by acidosis. As you can imagine, there's a lot of hydrogen ions that can displace the calcium, okay, from the albumin. So that can lead to low ionized calcium. Or alkalosis, which has less hydrogen ions, so there's increased binding of calcium to albumin. So there might be less ionized calcium as a consequence of that. Again, important to adjust total calcium based on the serum albumin levels. Any questions on this? Okay. So moving on to PTH. So parathyroid hormone is a 84 amino acid peptide, as you can see, produced by the chief cells in the parathyroid gland. And just like every protein, it has the pre-pro-PTH, pro-PTH, and then you have the final product, PTH. So all of these processes happen just like every other protein in the endoplasmic reticulum, then in the Golgi and all the other intracellular structures that process the protein before it is stored in the vesicles. So and when the signal for parathyroid hormone comes, then the vesicles are released to increase the PTH levels. So again, this is just to illustrate that PTH is tightly regulated. So calcium, PTH regulates calcium, but the release of PTH depends on calcium levels. So if the calcium is high, as the calcium goes up, the PTH levels go down. Okay, so that's normal response, because you don't need parathyroid hormone to mobilize calcium if the calcium is increasing. Okay, or if the calcium is going low, so if the ionized calcium is declining, the PTH level will go up. Okay, so the point is, the primary role of PTH is to maintain calcium homeostasis. Okay, and the PTH parathyroid gland has calcium sensing receptors. okay? And those sense the calcium levels and then adjust the release of parathyroid hormone accordingly, okay? I have another audience question, so you guys can. So when the serum calcium is low, parathyroid hormone corrects calcium back to normal through the following mechanisms except. All right, we're going to move on. Okay, most of you got it correctly. So the correct answer is osteoblast activity. So parathyroid hormone does increase bone resorption, and it does that through osteoclast activity, not osteoblast, okay? Also increases calcium reabsorption from the kidneys. It has a direct effect on the kidneys, and then also increases activation of vitamin D so that it can absorb more calcium from the intestines. So those are all actions of parathyroid hormone. And this is summarized on this slide, looking at if the calcium level is declines in the serum, there's calcium sensing receptors in the parathyroid gland will sense the low calcium and lead to release of PTH. Okay, PTH has direct effect on the bone to increase bone resorption. It has direct effect on the kidneys to increase calcium reabsorption from the kidneys. Then it has an indirect effect in the intestines through the action of activation of vitamin D in the kidneys to lead to increased calcium absorption, okay? So those are the three key strategies that PTH uses to increase serum calcium back to normal when there is low serum calcium. Parathyroid hormone increases bone resorption, resorbing osteoclast. Because you're resorbing bone, alkaline phosphatase, okay, is a marker of bone turnover, okay, and it can have increased alkaline phosphatase in the serum. So again, this is maybe a little bit beyond step 1 level, but you should know this because you're going to see it a lot as you progress through your career. There's preferential loss of cortical bone, okay, so you lose more cortical bone due to the effect of PTH. So, which is why when you're trying to assess for PTH excess, and you're trying to do check a bone density, you check for cortical bone instead of just cancellous bone. Where do you have cortical bone, for example? Which one is cortical? Why you guys haven't on MSK? You haven't? So cortical bone is a thick bone, right? Not the marrow, but the outer, the main bone, okay? So that's the cortex of the bone, okay? So you often have bones that have a lot of cortex, like the distal radius, distal 1/3 of the radius. You have mostly cortical bone. So oftentimes those are the ones, the site we use to assess for osteoporosis in patients that have hyperparathyroidism. So oftentimes if you see, again in clinical practice, if you see somebody check a bone density test, often it's the spine and the hip that we check for bone density, for DEXA, okay? But when you check this distal 1/3, that's often an indication that this patient is being assessed for possible hyperparathyroidism, okay? So just keep a little, tip. And then PTH can cause myelofibrosis if it's not detected on time. And, again, because we have, if you make any contact with any physician or if you go to the hospital for urgent care for any reason, you're going to get a chemistry panel. Okay, most chemistry panel have calcium. So it's often very uncommon that you have hypercalcemia that is undetected for several years. Okay. However, in before modern times, when these assays were so readily available, patients could develop things like myelofibrosis as a consequence of parathyroid hormone excess because it's not detected on time. And, it leads to these late-stage complications. And they can have things like subperiosteal resorption of cortical bone, things like you can see how lucent the skull is looking on this X-ray, and that's the effect of parathyroid hormone excess. In the kidneys, we talked about this kind of previously. The PTH has two key actions. One, it activates 1-alpha hydroxylase, which is the enzyme that converts 25-OHD to 125, okay, which is the active form of vitamin D. So vitamin D is activated by the effect of PTH in the kidneys to the active form, okay? Also, PTH stimulates resorption of calcium in the distal nephron. So that's also another important action. And it also inactivates phosphate transporter. Okay, so you have reabsorption of calcium and loss of phosphate. So the net effect of PTH is increased calcium, decreased phosphate. Okay? So, and this is important because if you see on your boards, and most times if you have an increased calcium and decreased phosphate, you have to think about PTH action. Or if you have decreased calcium, increased phosphate, it means lack of PTH action, oftentimes. So those are the effects in the kidneys. And then I'll pause for any questions on PTH action. So we're talking about parathyroid hormone kind of introduction. Now we're going to move over to hypercalcemia. But is there anything we talked about so far that is not clear to anybody? Okay. So we'll talk about hypercalcemia. Clinical manifestations of hypercalcemia, you can have, when it's mild. So mild, calcium is less than 11.5. Usually, I think the upper limit of calcium is about 10.5. So if you have calcium that is high but not like beyond 11.5, oftentimes you can have like polyuria, polydipsia. So you can have, because it's nephrogenic diabetes insipidus, very high calcium levels. So and then you can have dyspepsia, depression, cognitive impairment, okay? So these are mild. As you can see, some of these are very non-specific, not very specifically attributable to calcium being high. On the other hand, if you have more severe hypercalcemia, you can have anorexia, okay, nausea, apathy and fatigue, muscle weakness, constipation, okay? So these are more severe symptoms. And then you can have nephrolithiasis, okay, kidney stones, okay? That's very, often very, if you have a patient that comes with kidney stones, you should always obviously check the calcium, because hypercalcemia is one of the key causes of kidney stones. And then which can result in urinary obstruction, urinary tract infection, okay, and then renal failure. And then you can have loss of cortical bone, like we talked about, more advanced and more prolonged hypercalcemia. And then pancreatitis. When you have calcium, can cause pancreatitis, hypercalcemia, due to effect on the secretion, the secretory ducts in the pancreas. There's, in more severe conditions, you can have soft tissue calcifications, and then osteitis fibrosa cystic, again, essentially fibrosis of the bony matrix that we talked about, bone marrow. And then you can have in EKG changes is shortened QT interval. But, like we talked about, more than 50% are asymptomatic. So one of the key ways that we find hypercalcemia, like we talked about, is on lab evaluation. So patients don't have symptoms, but you check their lab for something and you see that their calcium is 11.2, and you check it again, it's still high. So that then would initiate some workup for hypercalcemia. Most patients don't present with symptoms of hypercalcemia. Okay, in fact, part of some of the management approach to hypercalcemia involves even leaving it alone, depending on how severe it is. Sometimes we don't do anything. All right, another question for us to discuss. The most common cause of parathyroid hormone-mediated hypercalcemia is which one of the following? Okay, let's see. Okay, so most of you got it correct. So all of the options can cause hypercalcemia, okay? Parathyroid cancer is very rare. It's not, I'm glad that nobody picked it. You know, it's not the number one cause, but it's not a common cause of hypercalcemia. It does, if it's present, you will have hypercalcemia. But most hypercalcemia is not because of parathyroid cancer. In fact, parathyroid cancer causes a more severe hypercalcemia. In endocrinology, if you have calcium like 15, you should think about parathyroid cancer. But for you, you should just know that it's one of the possible causes, but it's not the most common cause. Multiple parathyroid adenomas do cause hypercalcemia, obviously. However, again, it's not the most common cause. Okay, and when do you have multiple parathyroid adenomas? What condition do you normally have that? Under what conditions? I can't hear you guys. What causes multiple, instead of single adenoma, to cause multiple adenomas? An example. Say whatever it is. Okay, good. You know it, but you have to say it. So MEN, right? So MEN1 is one of the causes of, where you have multiple parathyroid adenomas. Okay, so in clinical practice, when you have that, a patient comes with multiple adenomas, you should think about MEN. So that's how you make the connection, right? So if you know that this is one of the causes of multiple adenomas, and it's not common to have multiple adenomas, with the exception of patients that have things like renal failure. So when you have renal failure, you can have secondary hyperparathyroidism. That can lead to, where you have hyperplasia of multiple glands. So sometimes it might be looked at as multiple adenomas. But, strictly speaking, when you have patients that have, one adenoma is making too much hormone, they don't have any renal disease, that should, number one suspicion should be MEN1. Okay? And then parathyroid hormone-related peptide. So again, that is not PTH mediated. So it's a non-PTH, even though it's parathyroid hormone-related. We'll talk about it later. But it is not PTH mediated. So by far, the most common cause of parathyroid hormone-mediated hypercalcemia is a single adenoma causing excess thyroid hormone production, excess parathyroid hormone production. So hypercalcemia, the way you think about hypercalcemia, always remember, anything calcium, think of PTH-mediated, non-PTH-mediated, okay? So PTH-mediated or PTH-dependent is, of course, primary hyperparathyroidism, tertiary, okay, FHH, familial hypercalcemic hypocalciuria, and then lithium, okay? So secondary can also cause hypercalcemia, but it's usually you have secondary hyperparathyroidism in response to low calcium, okay? So calcium is low, the parathyroid level goes up to correct it, okay? So most times you don't get hypercalcemia. You have normal calcium. So the clinical presentation of secondary hyperparathyroidism is normal calcium and high PTH. Okay, and that's because, remember when we talked about primary, if something is primary, it means that the endocrine organ is the cause of the problem. So if you have primary hyperparathyroidism, the problem is the parathyroid gland, right? So it's making too much hormone. Secondary hyperparathyroidism is something outside of the parathyroid gland, which is hypocalcemia for whatever reason. That will cause the parathyroid gland to respond to try to correct the hypocalcemia. So that's secondary hyperparathyroidism. You can have that in things like when you have renal failure, okay, because the kidneys has decreased ability to activate vitamin D and other effects of the kidney in calcium metabolism. And when you have end-stage kidney disease, you can have secondary hyperparathyroidism because of that hypocalcemia. The parathyroid is trying to correct the hypocalcemia that results from kidney disease. And tertiary is often, when you have chronic secondary hyperparathyroidism. So the parathyroids are constantly making more and more PTH because of chronic hypocalcemia. So even though it's correcting the calcium back to normal, but because the parathyroids are continuously working, okay, making more and more hormone, over the course of several years, they can get hyperplastic, and they can start to function excessively and start making excess parathyroid hormone, and that can lead to excess calcium. Okay, so that's when you talk about tertiary hyperparathyroidism. So primary, secondary, tertiary. So primary is what you're going to see, for your boards and most times, most commonly, but you should know about the other conditions. Okay? Then PTH independent. So these are things that cause high calcium, but not because of PTH. Okay? So you think about things that cause hypercalcemia, but not caused by PTH. So malignancy. Okay, we talk about malignancy. Granulomatous diseases, drugs, so vitamin D, obviously, and thiazide diuretics. Thiazide diuretics cause reabsorption of calcium in the kidneys, so they can increase the serum calcium. Then being immobilized. Okay, so remember that the cells in your bones, okay, they sense the weight that you put on the bones. So there's the effect of weight on the bone. And by having weight on the bones, weight-bearing activity, you stimulate the bone to recycle and to form bone and to be healthy, which is why you encourage walking for patients. But if you stay immobilized for long periods of time, the bone will start to lose its density. You start to have more of osteoclast activity, okay, in the bone when you're immobilized, okay, which is why, again, things like, people who have patients in the hospital who have been on, bed-bound for several months or weeks, and they come in the hospital, their calcium is normal, and after 4, 5, 6 weeks, you start having hypercalcemia. Okay, that's because laying in bed, you're losing that weight bearing effect on the bones to stimulate bone formation and leads to loss of bone density. And then, of course, hyperthyroidism, we talked about this already, and other hormones that could lead to loss of calcium. Okay? Another example is patient, when we're talking about bone, weight, effect of weight bearing on bone. Think about astronauts. Okay, astronauts, if they don't, you see them, and I'm sure you've seen astronauts running on the treadmill, and they have something to tie them down. That's because they want to bear weight. But if you're weightless in space for many months, one of the complications is hypercalcemia and loss of bone. So they run on treadmills with that tie them down so that they can actually exert that weight, that shear effect on the bone to stimulate bone formation. So primary hyperparathyroidism, often caused by a single adenoma, more than 80% of the time. Okay, sometimes it can be hyperplasia. Okay, not as common, but about 10% hyperplasia, and then carcinoma less than 1%. Okay, so and as you can see from this picture, the parathyroid glands are usually four, and they're usually located behind the thyroid gland. They have common blood supply with the thyroid. So again, manipulation of the thyroid, either for surgery or removal of the thyroid, it's one of the most common causes of hypoparathyroidism because of either removal of the parathyroid glands or disruption of their blood supply. Okay, so that's something to know. And again, in the hospital, whether you're doing surgery, medicine, you're going to see this, okay? We get consulted all the time. Patient is post-op for thyroid, some thyroid condition, and they develop hypocalcemia. And in the case of primary hyperparathyroidism, we talked about how calcium is tightly regulated by parathyroid hormone and how parathyroid hormone responds to calcium levels. In primary hyperparathyroidism, as the calcium increases, so does the PTH. Okay, so it doesn't, instead of PTH to go down in response to hypercalcemia, it stays elevated. So that is, the typical clinical presentation of hyperparathyroidism causing hypercalcemia. So this is pretty straightforward. So treatment options for primary hyperparathyroidism. So conservative management, we talked about this. If patient is asymptomatic, okay, and they don't have complications related to the hypercalcemia and the calcium levels are not too high, okay, then we can monitor it, especially if they're older patients. So there are different things. That's a specific set of criteria we use, which you don't need to know at this point. But a lot of patients that have primary hyperparathyroidism and they're asymptomatic do not undergo surgery. Okay? However, if they are younger, okay, or if they have more severe complications, like if they have osteoporosis, for example, okay, or if they have kidney disease as a consequence of hypercalcemia, then definitely we consider them for surgery. And then there's also medical management where you can give medications that increase calcium resorption into the bone, or that lead to has different effect on the calcium sensing receptors that can lead to help. Those are options for medical management. So things like bisphosphonates, these are medications used to treat osteoporosis, and they can lead to increased absorption of calcium in the bone. That can reduce the calcium in the serum. Then there's a medication called Cinacalcet or Sensipar. Cinacalcet is a calcium. It binds to the calcium sensing receptor to kind of make the calcium sensing receptor believe that there's more calcium than there is, so that it kind of tries to reduce the amount of PTH production. But again, you don't really need to know the details of all of this. Just know that there is medical management option for primary hyperparathyroidism. Some of these are things that you're going to see in your step 3, when you're actually doing clinical. What are some other causes of hypercalcemia? We already talked about some of this, so I'll skip this slide. But I wanted to focus on hypercalcemia of malignancy. So again, it's the second most common cause of hypercalcemia. So the way I think of it is, when you have hypercalcemia in a clinic patient, it's most likely primary hyperparathyroidism. When you have hypercalcemia in a hospitalized sick patient, it could be, the most common cause is usually malignancy. Okay, so think about that. If you have an unexplained hypercalcemia, think about malignancy. And malignancy hypercalcemia occurs in about 10 to 20% of all cancer patients. Okay, and the reason is because different things: solid tumors with metastasis and bone resorption. So that can be the direct effect on bone resorption. Also, you can have humoral factors, okay? So we talked about PTH-RP, which is PTH-related peptide, okay, which is produced by, cancer cells. So it's not really, it's not parathyroid hormone, but it has parathyroid hormone-like action, okay? And that leads to kind of a similar effect as having excess parathyroid hormone. And then you have hematologic malignancies like multiple myeloma and lymphomas that can also lead to hypercalcemia. And looking at we talked about direct bone invasion, so that is most common by breast and non-small cell lung cancer, and then cytokines produced by cancer cells. But you can have humoral effect. So humoral, like PTH-RP, like we talked about, this is the structure of the PTH-RP, and that can lead to activation of the PTH receptor, even though it's not PTH. So because you're activating the PTH receptor to cause increased calcium, the PTH level will be low. Okay, the native PTH is going to be low. So it's one of the causes of non-PTH mediated hypercalcemia. Does that make sense? Okay. And then when you have granulomatous disease, these are things like sarcoidosis, tuberculosis, the lymphomas are not granulomatous, but they also have similar effect. And what happens is 1-alpha hydroxylase is the hormone that enzyme that stimulates conversion of 25-hydroxy to 125, which is active vitamin D. So by increasing the 1-alpha hydroxylase, these granulomatous diseases produce 1-alpha hydroxylase, okay, just like the kidney does under the influence of PTH. But this is pathologic. So they make excess 1-alpha hydroxylase. So that leads to increased 125D. So there's excess vitamin D that binds to the vitamin D receptor to increase calcium and reduce the PTH. And as you can tell, because vitamin D, which we're going to talk about, in the subsequent slides, vitamin D is produced by by sunlight, UV light, So in patients that have problems with excess vitamin D stimulation from 1-alpha hydroxylase, it makes sense that if you have a lot of 25-hydroxy-D made by sunlight during the summer months, you're going to have more 125, okay? So essentially, it's kind of a seasonal hypercalcemia that you might see in patients like this, where during the summer months, they have more calcium, more hypercalcemia than in non-summer months. And then FHH, familial hypocalciuric hypercalcemia. So this is an interesting disease condition where you have an inactivating mutation of the calcium sensing receptor, an autosomal dominant inactivation mutation of the calcium sensing receptor. Like we talked about, the calcium sensing receptor is responsible for, telling the parathyroid gland, this is a calcium level, and this is what, if it's low, it will tell the gland to make more parathyroid hormone. If it's high, it will tell it to make less, right? So when the calcium sensing receptors is to sense normal calcium as being low. Okay, so what does that mean? It means that it will tell the parathyroid glands to make parathyroid hormone. Okay, even though it's, it don't really have true hypocalcemia. So by increasing the PTH level, the parathyroid hormone will increase the calcium level up to that particular threshold, okay, and results in increased calcium, okay. So it's often not pathologic just because the calcium, the defect also happen. There are also calcium sensing receptors in the kidneys, so those kidneys also sense that the calcium in the serum, which is high, will sense it as normal, okay? And by doing that, they don't clear the calcium through the urine. So essentially, there's no hypercalciuria like you will expect when you have hypercalcemia, okay? So bottom line is, the net effect is essentially it's a benign condition, okay? There's no clinical implication, even though the calcium is a little bit high, but it doesn't have any clinical effect. And in terms of management, you don't do anything. Essentially, you monitor it. So that's why when we're evaluating patients in clinical practice with hypercalcemia, one of the key tests that we check is to check their urine calcium. Because you have hypercalcemia and you have hypocalciuria, then you have to think about this condition to make sure that it's not a familial hypocalciuric hypercalcemia. Because the normal response of the kidneys to hypercalcemia is to increase the calcium in the urine. But if you don't have that happening, it means that there's a defect in both the parathyroid and in the kidneys. Okay? Is that too confusing? Okay, good. And then I kind of briefly talked about secondary hyperparathyroidism. So this is where you have low calcium, okay? So that's the first thing that happens. There's low calcium. What happens? The calcium sensitive receptors identify that it's low calcium, increases PTH to correct the low calcium. Increasing the PTH to correct the low calcium leads to normal calcium. Okay, so the PTH responds to a low calcium state and gets increased calcium back to normal. And of course, as you can tell, most of the calcium comes from the bone. So secondary hyperparathyroidism is not necessarily a good thing. Often means that you don't have enough calcium and the body has to borrow calcium constantly to make it normal. So, and most of the calcium comes from the bones, right? So that can be a cause of bone disease as well. So some of the causes could be either we're not taking enough calcium in the diet. So that's why it's important to take calcium, adequate calcium in the diet to avoid, weakening the bones. Also, kidney disease, you're not, converting enough of the vitamin D or the kidneys are not functioning optimally for calcium metabolism. Or if you have vitamin D deficiency, not enough vitamin D. So these are all different causes of secondary hyperparathyroidism. As you can tell, all of these things are outside of the parathyroid gland. They are defects that lead to low serum calcium. And because of the low serum calcium, the parathyroid glands respond to increase the PTH secretion. All right, so we've come to a break. So let's take about 10 minutes break. And we'll come back around 10:05. I got you guys something. So you can have that for your break. Okay? Maybe this will wake you guys up a little bit. So you can just pass this around. Welcome. So we'll be back around 10:05, okay? All right, so let's go ahead and get started again so we can finish up on time. So during the break, some of you raised a question about what was the question? Osteoporosis, effect of PTH on osteoblast versus osteoclast, right? So just to clarify, so then if you have sustained exposure of PTH to the bone, you're going to have net osteoclast activity. However, osteoclast activation is through the effect of osteoblast. So PTH primarily causes osteoblasts to produce certain substances that now stimulate osteoclast production. Okay, I didn't want to confuse you guys, so I didn't, but understand that, yes, primarily the first signal for PTH action on the bone is through the osteoblast. So they produce substances. There are different things. Again, you don't need to know this, but things like rank ligand, receptor activator of NF-kappa B, rank ligand. So this rank ligand binds to rank, and that leads to activation of osteoclasts. Okay? But if you have sustained PTH action, that activation of osteoclast now becomes the predominant action on the bone. So I'm glad that you guys read it in the textbook, so that's good to know. But just know that net effect, sustained PTH is bone loss because of more osteoclast activity, and net effect of intermittent PTH is bone formation, net bone formation. So the next section is hypocalcemia. So start with a question. On the morning after total thyroidectomy for papillary thyroid cancer, a 60-year-old woman complained of numbness and tingling of her lips and fingertips. Which of the following is most likely reason for her symptoms? Okay. I think should be straightforward, I hope. Okay. So, yeah, most of you got it correctly. So it's, again, anytime you hear thyroid surgery and symptoms of hypocalcemia, it is most likely that there is either removal of the parathyroid or disruption of the blood supply of the parathyroid gland, okay? Excess excretion of calcium in the urine is usually not necessarily tied to parathyroid surgery per se. And hypothyroidism, again, it could cause, if you have, long-standing hypothyroidism, that will not cause, acute symptoms. Like this. So even acute hypothyroidism will not cause things like numbness and tingling. You're going to have things more like, I remember that, I'm sure you talked about this in thyroid. What's the half-life of thyroid hormone? Did you guys talk about this in thyroid? Like, how long does thyroid hormone stay in the body? So thyroid hormone, like T4, has a half-life of about 7-8 days. So if you have, loss of the thyroid gland, you don't expect to have immediate profound effect because it's bound to protein. We talked about this in the early class, the introduction class. Because thyroid hormone is bound to thyroid binding globulin, that prolongs the action of T4 to 7 to 8 days. Okay, so even if you have complete loss of your thyroid gland, it's not going to cause an immediate profound effect. And then resistant to PTH is not the and vitamin D deficiency. So I'm glad none of you picked it, but removal of the thyroid, parathyroid is the most likely reason in this case. All right, so clinical manifestations of hypocalcemia. So neurologic, so because of the effect of calcium in nerve conduction, you can have hyperreflexia, twitching, muscle cramps, tingling and numbness. Cardiac effects, EKG changes, prolongation of the QT interval, arrhythmias and heart failure if nothing is done to correct the cardiac effects. And then musculoskeletal, dry skin, coarse hair, brittle nails. You can also have, if it's not corrected promptly, long-term, you can have osteopenia and osteoporosis, okay, because of the effect of not having. Remember that bone is made up of calcium and phosphate. So if you have prolonged hypocalcemia, then you're going to have a net loss of bone. Trousseau sign, again, I don't know if they will, this is something that you will see in your steps or, but if you have a scenario where they say that a patient develops spasms, what triggers these spasms? Do you guys know? What will trigger the spasms in hypocalcemia in a Trousseau sign? Low calcium, but what do you do to make the spasms come? Blood pressure, yes. So the story is going to be that the patient came in the hospital complaining of numbness and tingling, and then when they were taking their blood pressure, their hand went into spasm. Okay, so that is specific, very, very highly suspicious for hypocalcemia. On the other hand, you have Chvostek sign. So again, which nerve are we tapping here? Facial nerve, okay? So you tap on the facial nerve, and because of the hypocalcemia, it's hyperexcitable. So you have twitching. Depending on which branch you tap on, you can have twitching of the eyelid or the corner of the mouth or over the forehead. So depending on the branch of the facial nerve, you can have different twitching responses because of the muscle twitching. And this is we see this all the time, patients that have hypocalcemia. During your clinical rotations, you're probably going to run into a case like this. Try to elicit this sign and see if you can, get it. Causes of hypocalcemia. So once again, it could be PTH or non-PTH mediated. So if it's PTH mediated, you're talking about the parathyroid gland is not working for whatever reason. So it could be post-operative. So you took out the parathyroids as a result during surgery. Or it could be autoimmune destruction of the parathyroid, okay, or congenital. This is a syndrome, the George syndrome, that have this constellation of symptoms. Dysmorphia, you can have cleft palate, cardiac defects, immune deficiency, and hypoparathyroidism. Or you can have infiltration of the parathyroid gland by iron or copper, okay? Or, and that infiltration can cause loss of function. Okay, so hemochromatosis, for example, excess iron, that can lead to multiple endocrine organ failure. It's a known cause of hypofunction of endocrine glands. Then idiopathic. And then you can have pseudo-hypoparathyroidism, okay, which is where you have the parathyroid glands are working, okay? However, there's loss of... What's the defect in pseudo-hypoparathyroidism? Does anybody know? Yes, PTH receptor. So when you have defect in the PTH receptor, remember that PTH receptor is a G protein coupled receptor. So when you have defect in the G protein, GNAS, G protein stimulatory, so it's defective, so it doesn't respond, essentially. So when even though PTH will bind to the receptor doesn't transmit the signal to the second messenger. So the message doesn't get transmitted, even though it's binding. So in patients like this, there's low calcium, and what does low calcium do to the parathyroid hormone level? It goes up. So you have very high PTH, but calcium is low because the receptors don't respond. There's no message that is being transmitted. Okay, so that is pseudo hypopara. So that's why it's pseudo, okay? And then magnesium deficiency. Magnesium is a cofactor for PTH action and secretion. So when you have low magnesium state, it's very low, you can have a loss of PTH action. And then non-PTH mediated, this is where you have either conditions that decrease the availability of calcium to the body through poor absorption or increased resorption to the bones. So things like celiac disease or bypass surgery, when you have gastrointestinal issues that lead to decreased absorption of calcium. Drugs, that lead to increased deposition of calcium to the bones, or vitamin D deficiency, so not having enough vitamin D for the action of vitamin D. Or you have osteoblastic metastasis, so some bone disease. So we talked about how malignancy can cause bone loss, but there are some few osteoblastic metastatic diseases that can lead to blast formation, again, not common. And then there's hyperphosphatemia, because calcium and phosphate tend to bind. So if you have very high phosphate levels, like in renal failure or tumor lysis, when you have a cancer that is breaking down, or rhabdomyolysis, muscle breakdown, you can have complexion of calcium with phosphate that leads to low calcium levels. So pseudohypoparathyroidism, there's lack of response to PTH receptor, of the PTH receptor to PTH from defective G protein, which is the second messenger. So PTH levels are elevated, but patients present with symptoms of hypoparathyroidism. So even though there's very high PTH, they present like, hypocalcemia. So you can confirm the diagnosis by measuring the amount of cyclic AMP, which is the second messenger for PTH in the urine after administration of exogenous parathyroid hormone. Okay? Does that make sense? Okay. Calcitonin is a 32 amino acid peptide. Okay? It's produced in the parafollicular C cells of the thyroid gland. It's released in response to high serum calcium. So remember that. So, and it's inhibiting bone resorption by osteoclasts. So we often use calcitonin when we have high calcium levels. We want to lower it. It's produced in the medullary thyroid cancer that originate from C cells. So we often use calcitonin. One of the clinical uses of calcitonin is to monitor for a medullary thyroid cancer. When you're treating medullary thyroid cancer, we check calcitonin as a tumor marker. It tells us if the cancer is there or if it's not. So after the removal of the thyroid, we use calcitonin to assess if there is any residual C cells, okay? Where do we see medullary thyroid cancer? Do you guys remember? Which syndrome? MEN, okay. 2, okay, so remember that. All right, so clinical use, besides, like we talked about monitoring for cancer recurrence, medullary cancer recurrence, we use it to treat hypercalcemia. So one of the first, it's quick, it gives quick action for calcium reduction in patients that have hypercalcemia. Like patient presents with hyperparathyroidism, calcium is, 12.5. We start with calcitonin. The caveat about calcitonin, which you do not necessarily need to know at this point, is that, but the effect wears off after about 72 hours. So when you give calcitonin, we often give it along with something else, like a bisphosphonate, so that by the time the effect wears off, something else, another medication is there to sustain the calcium lowering effect of the medication of your treatment. But it is used for treating hypercalcemia. And then also for treatment of osteoporosis. It's because of the positive effect on the bone, it's used, but it's a weak agent for osteoporosis treatment. And we rarely use it. Questions? All right, we'll move on to vitamin D. the function is primarily for bone mineralization and also increase both calcium and phosphate. Okay. We'll do audience participation again. So you can scan the QR code. Which of the following defects in vitamin D synthesis is responsible for elevated PTH in patients with chronic kidney disease? So why do you have high PTH in chronic kidney disease? What causes that? Okay, I have to move on. Okay, excellent. So most of you got it correctly. So 1-alpha hydroxylase activity, that's primarily in the kidneys. And, when you have kidney disease, that activity is not optimal. And so you have decreased conversion of 25 to 125 dihydroxyvitamin D. And by having that leads to, because the calcium is low, the 125 is low, PTH is stimulated to increase. That's why you have elevated PTH in CKD. And we'll look at vitamin D metabolism. Maybe some of these will be clearer. So looking at that, so I don't know, this is not very clear on the board, but it's on your slides. But the metabolism of vitamin D, like we talked about, you have the effect of the sunlight. So there are two sources of vitamin D, from food and from synthesized, from that synthesized on the skin. Okay? For synthesis, you have sunlight on the skin leads to 7-dehydrocholesterol activation, and that leads to formation of vitamin D. Then you have vitamin D 25 hydroxylase in the liver. So that's where, again, 25 hydroxylation happens in the liver. And then that goes to the kidneys, where you have 125 hydroxylase. Okay? That leads to the formation of the active vitamin D. This is influenced by PTH. So PTH influences formation of 125D, and in addition to the other effects of PTH. But the 125D has effect on the bone and on the intestines to lead to increased absorption of calcium and also effect on the bone remodeling that we talked about. So this is really important to remember. Egocalciferol and cholecalciferol, what's the difference between the two? Does anybody here know? This is more like for interest, not necessarily, where does egocalciferol come from? Do we make egocalciferol? No, we make cholecalciferol. So humans and animals make cholecalciferol. Egocalciferol comes from plants. Okay? So if you have a patient that you check their vitamin D level and they have very high egocalciferol, it means that they're taking large amounts of, vitamin D. Probably, but you can buy both. You can get both ego and cholecalciferol as supplements in the hospital, in the pharmacy. And the evidence says it doesn't make a difference much. Again, these are things you don't necessarily need to know for this level, but just know that there are two forms, from plants and from animals. Regulation of vitamin D. So when there's sufficient calcium, okay, so we don't need to get more calcium. So we don't need vitamin D activation. So what happens is that instead of forming 125, the kidney forms 24-25, which is an inactive form of vitamin D. Okay? But when there is insufficient calcium, then you have formation of 1 alpha hydroxylase activity to form 125 dihydroxy D. So instead of 24 hydroxylase activity, you have 1 hydroxylase activity in insufficient calcium state. That leads to increased calcium mobilization. So what activates calcium 1 alpha hydroxylase activity? Low serum calcium, low plasma phosphate, and then increased PTH. Okay? So vitamin D action, again, this is more like for redundancy and to help you to remember. In the intestines, increases calcium and phosphate absorption. In the kidneys, increases calcium and phosphate reabsorption. Okay, so positive effect on calcium and phosphate. And then in the bone, resorption and bone resorption from remodeling. Again, in contrast, parathyroid hormone has kind of opposite effects on calcium and phosphate. Okay, vitamin D has the same effect. Okay, increases both. PTH increases calcium, lowers phosphate. Okay. And then how would vitamin D deficiency manifest in children versus adults? So in children, you have rickets, and in adults, you have osteomalacia. The pathophysiology is similar. The difference is that in children, because the growth plates have not closed, you can have growth failure and skeletal deformities, like bowing and, of the legs because of the effect of the weight on the bones. You can also have, in adults, you have poor mineralization and osteomalacia, which can lead to fractures, bone pain, and bending. So these are, the different, but again, the pathophysiology is similar because of the deficiency of vitamin D. You don't have adequate mineralization of the bone that leads to different defects, depending on the age of the individual. Any questions? I think that's it. So, so this is the last session for this block. Like I mentioned from the beginning, you can reach out at any time if you have questions as you're studying for your exam. I think your exam is on Monday. And, feel free to reach out. I encourage you to review the slides. We had, the faculty, we made every effort to make sure that the content you have on your exam is covered in the classroom, okay? Of course, you need to read beyond that so that you can understand the contents better, okay? But make sure that you're going to have, I think, 60 questions. Each faculty is going to select questions based on what was taught in the classroom. So every faculty will select the questions for each of the sessions, okay? And, so again, we try as much as possible to make sure that everything on the exam has been discussed in class with you, okay? But I really encourage you to read, as you're preparing, read the textbook. I'm happy that many of you are reading the textbook, so do that so that you can have a more, global understanding of the concepts. Remember that, even though the NBM is, is the first, you have to pass that, but also your steps are important, right? So the content of the steps, is if you read the textbook, you can't go wrong on that. Okay, so make sure you broaden your scope and read everything. Okay, any questions? All right, so best wishes, good luck, and I'm sure I'll be seeing many of you, in a few years when you start doing your clinicals. I'll see you in the clinical during your clinical rotation. So all the best. Okay. Did you have something, Dr. Alexander? Okay. We have some chocolate, so you can still, I'm not going to take this with me, so.